Thanks to the organizers for this beautiful meeting. For hard cataracts, it depends on what technique, it depends on your skill and your intuition at that time, what you are going to do. If your intuition says that it's better to do SICS in a particular case, please go for SICS with a large wound. The patient, what matters to the patient is not phaco. What matters to the patient is vision. The patient should get good vision. So I am going to describe my technique for hard cataracts. Whenever the cataract is very hard, black, I do SICS or double SICS. But most of the time, I can manage with this technique. This is submarine chop technique. For submarine chop, after making the incisions and for better visibility, applying some visco over the cornea, we need to do a large rhexis. Size of the rhexis should not be less than 5.5 millimeter. I usually do a 5.75 to 6 millimeter rhexis. I usually use a utrata forceps. It depends on what you are habituated to. If you are using a needle all the time, it's fine. So with utrata forceps, I have done a large rhexis. And now hydrodissection is done at multiple points. Very small amounts of BSS is injected at multiple points. We cannot see the fluid wave. We can see the nucleus is lifting upward a bit. And then we mobilize the nucleus, apply visco again. In such cases, it is a better idea to do modified soft shell technique. You can use viscoat or chondroitin sulfate of any brand, and then underneath that you use HPMC. I usually manage with HPMC. And now the phaco needle goes in, some superficial lens matter is removed. I see the exposed part of the tip, it is little more than other routine cases. Now, no sculpting is done. Bury the tip just in front of the main incision, and it goes through the substance of the nucleus at a deeper plane under the surface, like a submarine goes underwater. That's why I have given the name submarine chop. Get a good crack. Don't do a lot of lateral separation. Come to the other side, rotating on 180 degree. And on the other side, I go to a deeper plane, hold on heminucleus with vacuum, and divide the nucleus into two heminuclei. In this case, on heminucleus is larger than the other, and I'm dividing this heminucleus into three parts. This is one, come to the bigger piece, and divide this into two parts. And now this is done with very high ultrasonic energy. Ultrasonic energy is 80%, flow rate is 45 ml per minute, vacuum is 450 millimeter of mercury. The machine is not a very high-end machine, it's a Oatley Cataracts 3 machine. And with this machine, I can manage most of the hard cataracts. And I have no financial interest, but most of the ophthalmologists cannot afford a Centurion. So with mid-range machine, we can manage hard cataracts. I come out managing half of the nucleus, inject more visco to protect the corneal endothelium, and now go again, and I come to the smaller heminucleus, divide it into two parts, and emulsify this. And this happens most of the time. Most of the time we can manage like this. But what if we cannot manage like this? What if we cannot crack the nucleus at on go? This is, in this case, the submarine chop failed. After rhexis and hydrodissection, go with the phaco handpiece, and here you see that I cannot get a good hold. I needed to go much deeper plane, but this didn't happen in this case. So when the submarine chop fails, I make a deep crater at the center, almost 80% deep. And then I start dividing the nucleus into parts and emulsify the pieces. Rest of the cases as in other routine heart cataracts. So thank you very much. If you have any questions, we can discuss on that.
Very nice surgery, excellent demonstration of how to deal with heart cataracts. Do you use any special viscoelastic to protect the endothelium?
Yes, I would say to the beginners to use modified soft shell technique like chondroitin sulfate first, and beneath the chondroitin sulfate you use HPMC, but I manage with HPMC in most of the cases.
So the point taken is have a slightly larger Lexus because you don't want to have any pull on the zonus, and also it gives you more space. And second thing is staining the capsule is very important because then it gives you a visibility throughout the surgery. And as far as your name of, what do you call it? Submarine chop. It looks exactly like the way I do it, but I didn't know, maybe I should call it snorkeling chop. No, because you've already taken the name of submarine chop. It's really a fantastic surgery.
Thank you very much.
And also the place where you start in the center or you move towards the incision? Will
I
it make a
start
difference?
just in front of the main incision.
Main incision.
Just
So
in
that
front.
you
So that
go
I
downwards
go deep.
towards
Yeah, go
the center.
downward, then at a deeper plane horizontally.
Okay, right. And a sharp chopper is necessary?
No, not sharp chopper. This is very small chopper, normal chopper. It's it's designed by me. It's just a modified Sinski hook. It is about 0.6 to 0.7 millimeter long.
And the tip is sharp?
Tip is not sharp. It's blank.
So
No,
you also
sharp
kind of
chopper
feed it
really
when
works.
It comes from periphery, so it's not
okay,
cutting
okay.
it.
So if you do a central chop, the sharp chopper really works because it cleaves your nucleus very nicely.
Yeah, but,
you should
yes,
really try it because
that's a
but your
good technique,
technique
but
is a
this
little
is-
bit different. You go from the periphery, you do a peripheral chop.
And I go near the chopper at the periphery. Phaco needle goes near the chopper.
So the needle traverses most of the nucleus,
yeah.
not the other way.
Yeah, okay, right.
Thank you very much, Dr.